Welcome everyone to today's webinar. It takes heart, expanding cardiovascular care access now. Before we begin, I'll walk us through just a few quick housekeeping notes. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. And if at any time you have issues with the audio or video, please try refreshing your browser. You can also submit any technical questions into the Q&A box, and we're here to help. With that, I am pleased to turn the floor over to Dr. Sanjay Gandhi to kick us off with some introductions.
Thank you, Sarah, and good afternoon. Thank you all for joining us on World Health Day for this webinar on expanding cardiovascular care. My name is Sanjay Gandhi. I'm an interventional cardiologist and head of medical affairs for Philips. As you all know, heart disease is the leading cause of death in the United States and across the globe. And to achieve better health for all, tackling heart health is one of the biggest challenges, but also one of the great opportunities ahead of us. At Philips, we're committed to advancing technology to support better care for more people. And in this session, we'll examine some of the challenges around access to cardiac care in the United States and discuss best practices and innovation. I'm joined today by three trailblazing individuals, Dr. Deepak Bhatt, Dr. Garth Graham, and Dr. Ami Bhatt, who bring very distinct perspective on access to cardiac care. For full disclosure, Dr. Deepak Bhatt and Dr. Ami Bhatt are not related by blood or marriage, but have both worked in the Mass General Brigham Health System. And before we dive into this discussion, I'm going to ask the panelists to introduce themselves. Deepak?
Wonderful being with you. I'm Dr. Deepak Bhatt. I am the director of the Mount Sinai Fuster Heart Hospital and the Dr. Valentin Fuster Professor of Cardiovascular Medicine at the Icahn School of Medicine at Mount Sinai in New York.
Thank you. Garth?
Garth Graham. I'm a cardiologist, and I work at Google, where I'm head of the healthcare and public health program at Google and YouTube.
Thank you. Ami?
Hi, all. Dr. Ami Bhatt. I was previously at Harvard MGH until 2023 when I came over to the American College of Cardiology, where I serve the role as a Chief Innovation Officer. I'm also the chair of the Digital Health Advisory Committee for the FDA, but I am not speaking on behalf of the FDA today.
Thank you. I think the combined experience in this room and what you bring to this discussion is amazing. So I'm looking forward to a wonderful discussion. Thank you all for being here. So, I'm based here in Cleveland. I know, Deepak, a long time ago, you were in Cleveland as well. And we have a network of 3 big health systems and a lot of community hospitals. And that is similar across many big cities across the United States. Despite all that, it almost takes 4 to 6 weeks to see a cardiologist. And these challenges are probably even worse in rural or certain urban settings. If you think of patients with certain geographies or patients with poor socioeconomic status, what is your experience with some of the challenges to cardiovascular access as you work in your health system?
I'll start with that. I think it's a challenge for cardiology and access. I saw that in Boston. I see that in New York. But I think it's also true for primary care. There's not just specifically a cardiology program. I've got to say, in both cities, really tough to get a primary care appointment unless you know somebody that knows somebody. Really pretty amazing that access to primary care is such a challenge, and subspecialty care perhaps even more so. And I think that is an underlying issue with our entire healthcare system. It's not just the 2 cities I mentioned, Boston, New York. It's true everywhere. I think it's something that we all need to work to address better. I think part of it is, one could say, a shortage, say, of primary care physicians, of cardiologists, of other subspecialists. But that, even if it is the correct answer, isn't something that can be solved in a week or a month or a year. Of course, increasing the physician pipeline would take much longer, and it might not be the right solution because by the time we do it, the whole model of healthcare might change. And at least in keeping with the theme of today's webinar, I think that we've got to figure out ways of leveraging technology to make humans more efficient. And that includes doctors. And I think a lot of what goes on in healthcare, this is especially true in primary care, but I think it's also true for much of subspecialty care, is rather rote. I mean, we're just doing the same thing over and over. We might not like to admit that, but in fact, what I tell a patient after a stent in terms of compliance with dual antiplatelet therapy, and we need to lower your cholesterol and diet and exercise and stay on your statin. I mean, that's pretty much the same thing and the same message. Might there be a more effective way of delivering it than having me say the same thing over and over to different people? Might there be value in group visits? Might there be value in other healthcare providers delivering the message? And surely they do. Might there be value in automating some of that and having an AI bot deliver some of those messages? So I think in the future, we've got to think about how we can do better with largely the same number of healthcare workers and probably the same amount of total resources, or maybe less, given all the fiscal challenges in healthcare and more broadly.
Thank you. Ami, you see this from a different lens, as being part of American College of Cardiology, and I see you travel quite often, even outside the United States. What is your perspective and experience with cardiovascular access, and what have you seen as some of the things that health systems are doing?
Yeah, this is great. Well, first of all, thank you for having me. Second of all, I rarely physically lean into the Zoom, but today, you hit it with the first question, right? This is our most pressing issue. Before I came to the American College of Cardiology, I ran outpatient cardiology at Mass General Hospital. One thing we did see is we went from 60,000 some clinic visits a year to over 70,000 once we started to implement telemedicine and think about care in the communities where people live. And so I think when we're talking about access now, in order to fix, if you will, or move towards fixing, as Deepak says, it'll take time, there's a few things we need to do. First is we do need to push care out into the communities where people live. Requiring them to come to tertiary centers, I think, is part of our bottleneck. And so pushing out requires a few things. One, technology, absolutely. But the other is a slight change from going from paternalistic or maternalistic care to partnership with your patient, right? The patient has to really be part of this equation in a way that maybe we've always wanted, but not as aggressively gone after. And interestingly, technology now helps us engage the patient in a way that they want to be engaged, educate the patient at the level they need to be educated to make it easier for us to deliver more care. So I think I like thinking about the tech side, not only for the clinicians, but also for the patients in enabling us to get care into the community. The second part, and I'll go back to what Deepak said about the use of technology, right, and efficiency. The other thing is we're not just talking about doctors and nurses. Yes, we have a shortage of those, but there are a lot of people who offer care globally. And we can use the word, community health worker for now in certain areas, allied health professionals, but there are so many people providing care. If we can use technology to help these individuals get the knowledge they need at the point of care, at the moment they need it, not to do some exquisite tertiary level of care, but really to triage sick from not sick, who needs care here, who needs care there. I think those two uses of technology, educating our patients and our clinicians, and then being able to really, I don't like the word upskill, get the right knowledge to the right person at the right point in time. I think those are going to allow us to expand how many people we can reach. And so at the American College of Cardiology, that's a lot of what we do, is work on how do we get care into the community? How do we get education to the people who need it? And lastly, you started with this, but I'll end with it. We do need to educate the pipeline. We need to start with the high school students, the college students, the med students, and we need to train people who look like the communities we're trying to reach. And so, we have several programs where we're really working hard on creating that pipeline, recognizing that may take years to decades.
Thank you, Ami. Dr. Graham, from a technology standpoint, I think both Deepak and Ami brought up technology. You work in a technology company. What is the lens that you bring to this?
Thank you. And I got to echo Dr. Bhatt's comments about being pleased to be here and being amongst such an esteemed group of colleagues. So I'll start us off in one tangent and then jump to the tech side, because so much of technology requires people and systems to work well. So it's important to understand the limitations there. But I came to this role at Google from a number of other different roles. I was Chief Community Health Officer at CVS Health, where we worked in expanding access to cardiovascular care through a lot of what happened through the retail experience. And then before that, I was in academics, and then before that, in the federal government as an Assistant Secretary of Health. So I've seen this concept of how we address chronic diseases from so many different lenses and viewpoints. And also as a practicing cardiologist for a long time as well, including parts of rural Missouri. And one of the things to understand, and I think Dr. Bott, Amy Bott, said this so well earlier, in terms of understanding the levers to pull on, and different phraseologies for those levers, community health workers, other kind of levers. But there's so many levers outside of just the specialty care arena that are important, that impact the overall patient journey and the overall patient experience. And so being in different roles, I've seen that unfold. I can tell you that, as cardiologists or specialists of different kinds, when we see patients, we're seeing them at the tip of the iceberg. A lot has gone into their disease experience and their life experience that's resulted in that plaque building up way before they get that stent that Dr. Deepak Bhatt mentioned before. And so it's important for us to recognize, what we can do along that journey and how that's particularly important. Now, from the tech side, and we're going to talk a little bit more about that as we get on. There's so many different ways to understand, how technology from machine learning and all the different components before we even get in talking through the different concepts of how we bring large language models to scale in a way that is beneficial both to the clinician and the individual patient. So there's a lot of different tools to pull on, but the concept to understand here is the patient's at the center. It's a patient journey, and it's how we are able to impact that journey that's going to allow us to be the most effective.
Yeah, thank you. I just have two follow-up questions, one for Deepak and one for Ami. So Deepak, maybe you said, for the patient who gets a stent, you have the same message, same things, and it could be done automated more effectively. But are there any ways, or are there thinking in your experience or practice, where trying to see patient not getting the stent in the first place? I think, Garth, you mentioned it briefly as well, like preventive therapy. So by the time the patient gets to a stent, maybe it's already kind of down the line and it's the tip of the iceberg that we see. Are there certain things we can do for population of patients being served by the health systems?
Yeah, absolutely. I think prevention is key and is something that will be increasingly the focus of cardiovascular care and cardiology practices. Part of that will involve population health strategies. That is where a subspecialist, in this case a cardiologist, I believe would sit at the apex of a care team and manage a number of other healthcare professionals who are delivering care to a very large number of patients. So instead of it being one cardiologist caring for one patient at a time for conditions like dyslipidemia and hypertension and excess weight, diabetes, et cetera, where it'll be a preventive cardiologist at that apex managing the care of hundreds, if not thousands of patients. I think that could be a much more efficient way to control risk factors than the current model, which does work for some patients, but is largely pretty inefficient and certainly hard to scale up in a cost-effective manner. And I also think many times nurses do a better job with an algorithm than specialists or subspecialists do. And part of the problem with being a subspecialist is, you're an expert, that's why you're a subspecialist, but it also means that you may feel that deviating from the guidelines is what makes you special or a subspecialist. And sometimes that is the right thing to do. I mean, every patient's got to have individualized care ultimately. But for some things, if the LDL is 200, well, it needs to be treated. And if it's not being treated, whatever care is being delivered to the patient, whatever healthcare system they're in, is failing. So I think that a population health-based strategy really is going to play an even larger role in the future than it does now. One thing that would have to catch up, though, to make that much more of a reality than it is presently is there has to be a reimbursement scheme that actually promotes that approach, which right now sometimes there is, but usually there isn't.
I think that's a big challenge of how do you get care that prevents rather than fee for service that the current models kind of reward the health system with.
Yeah, but you can envision a healthcare system where, you've got AI deployed that's monitoring for patients with risk factors that are out of control, and then contacting those patients, arranging for visits. We're actually trying to do things like that right now in the Mount Sinai healthcare system. So, those approaches, I think, have potential value to the patient and improving the health of populations of patients, and hopefully doing it in a cost-effective manner.
Can I jump in for 1 second?
Yeah,
we are
more than
doing
a
that.
second.
Yeah, so we have a program driving urgency in LDL screening. And the practices, multiple practices, thousands of clinicians and patients have agreed to participate, where we literally just find, hey, you haven't had an LDL drawn. You really should have one. Message to the clinician, message to the patient, right? It's a relative. Now we're trying the messages, right? Part of the work that's being done is what is the right message that gets the patient to engage, it gets the clinician to engage, because there's a lot about adult learning response that is known in other fields that we in healthcare haven't worked on. But yes, you absolutely see increased engagement of testing for things that are so basic in the guidelines that primary care and cardiologists should be doing. But there's just so much on the average. I mean, I look at my primary care friends, and I, for, a lifetime, have always thought, wow, like for you to take on all of that, right? Anything that comes in the door, that is a group of people who I have great respect for. But what can we do to help with some of these things? And so I think Deepak's exactly right, that those are the kind of population health measures that we can do now. What we have to be careful about is the hard stop. Because when EHRs first started, and for those who are listening who experienced that, right, in 2016, I remember it took 17 clicks to make something about Coumadin go away in my system, right? Like the only number I remember from this whole AFib anticoagulation thing was 17 clicks. That, hard stop wasn't the way to do it. So let's use what we learned from other disciplines and interact with people in a way that makes them more likely to participate in certain life-saving measures that are very simple but could really make a difference, and move care upstream, as you said, Sanjay, because finding that LDL and treating those numbers earlier is what ends you up not needing the stent. But how do you find those patients? And I think that's exactly where AI is already helpful.
I think I was going to ask you something else, but I just see a question here pop up from Dr. Stephanie Almaden, in saying, is there a way to get an expedited referral priority to CV subspecialty? So if we're going to have, outreach upstream and get all these referrals, is there some way to use algorithm or AI to improve that CV subspecialty referral and prioritization?
I'll start with an ACC lens, then hand it over to the other Dr. Butt for the academic center lens, maybe. One thing we're seeing a lot more of now, and they come to us because of knowledge, guidelines, et cetera, is, are there ways to use AI to screen for diseases earlier and to identify them when they're with the primary care physician? Because we have a lot of diseases that we diagnose very late. And it turns out that there is a lot of technology that can help us diagnose things earlier, especially rare diseases. Let's take hypertrophic cardiomyopathy, amyloid, even pulmonary hypertension. And oftentimes that upstream diagnosis is long before you get near a cardiologist. It is with the primary care or the family practitioner. Then what? And so Deepak, I'm sorry, I'm challenging you. Because you're right, 4 to 6 weeks to see somebody is a long time, and the patient's nervous the whole time. You don't even sometimes want to put those things in place as a primary care, knowing that I'm going to have a bunch of diagnoses I'll give out, and then they'll just sit here and be stuck, right? So it's hard to get these systems in place. And so now there are companies that are actually going to telemedicine first. Let us teach you a little bit about this disease. Let us figure out what's happening. Let us help bridge that gap until you can get fast-tracked, if you will, to a cardiologist. And so these companies, I think, all exist because, or these systems of companies exist because we still have a problem in access to care at our major centers. Deepak, with that, let me hand it over to you.
I agree with everything you said. I think it's a real issue at academic centers and non-academic centers. Cardiology practices, this from your role in ACC are spilling over at the brim. There's just a lot of patients, and especially post-pandemic, it seems like practices are busier than ever. So I think figuring out ways to keep the patients engaged, informed, perhaps to keep them from getting too anxious while they're waiting to be seen, is really useful. Although sometimes perhaps they should be anxious if they have a large aneurysm. Maybe 5.4 isn't quite at that limit. I think they're waiting a little while is okay. But let's say it was 7.4. They should be anxious, and hopefully the system doesn't make them wait several weeks or months for an appointment. And that might be a way triaging those sorts of requests. Maybe with the use of algorithms that are AI enabled to just sort of say, hey, this one actually can't wait 2 months to be seen. This one, yeah, maybe it's not great they're waiting 2 months just from an overall patient satisfaction and service perspective, but it's actually not the end of the world for them to wait 2 months. So I think we have to figure out better ways, again, with the resources at hand that we've got, to try to make sure patients are getting timely care. I mean, this is a problem, in urban areas. It's a problem in rural areas, maybe a little bit worse in rural areas. Well, not maybe, definitely worse in rural areas. And of course, it's true across the socioeconomic spectrum, but exacerbated at the lower end of the socioeconomic spectrum. So we've really got to do a lot more in terms of figuring out how to get patients timely care, get them seen by the right type of healthcare provider. In the case of subspecialists, access when they need it in as timely a way as possible.
The one thing I'd add is the one rate limiting challenge with a lot of this is still adequate staffing. And, even when we have both the processes that can potentially drive people earlier, one kind of a bottleneck in the process is still the challenge we face with having a skilled, qualified professional who are either in a location that is available to the patient or in some other case available. And so this is probably a role for telehealth and kind of other capacities when appropriate, that context. But the idea that the rate limiting factor to many of these challenges is still going to be staffing.
Yeah. And I think one of the other challenges that is being brought up in the chat here is also compensation models. People, you alluded to it, there's work-based compensation currently that may not do justice to population-based initiatives. And also, the role of payment system for telehealth, for example, there's reimbursement, there is higher uptake, but lack of reimbursement may be a challenge that we get there. Dr. Graham, I'm just curious from your experience in CVS Health and expanding access through a very different lens, right? The Minute Clinic, bringing that care in the community. And I think, Ami, from your experience with the workbook that ACC published on cardiology care at home. So maybe I'll start with Dr. Graham first. So what is your experience there? Like, how did CVS do it? What was, some of the experience that they had from that, learnings from that?
Yeah, I think the nurse practitioner model was one of the kind of major levers that we used on the CVS standpoint during that whole experience, and still continues to work very well. And what I would say are two components there. One is understanding both as the clinician and the patient the various tiers and levers of care, and that there are some things that are the more we have expanded professional capacities that can handle those disease entities are a good thing. And of course, then when you get to more complicated care, that's when a lot of this stuff still gets more challenging, because that's when you still need more specialists, and where we still continue to have a challenge in terms of the end number of specialists we have available, particularly in rural populations once you get outside of the coast or outside of the big cities. So I think my experience there was certainly the role and the positive role that allied health professionals can have, as well as other non-doctor professionals, but then still recognizing the central role that doctors, in particular cardiologists, play. And again, the rate limiting factor then in terms of access to care based on the numbers of those cardiologists available, particularly as you get into rural populations.
So if I may, I'm looking at some of the questions in the chat and then kind of responding to that with healthcare models, and I'll try to do it all together. When we are seeing patients in the office as a cardiologist, there's a few things. One is there's probably a population health mechanism, as the book mentioned, where the hypertension patient doesn't need to drive 45 minutes to see me every 6 weeks, et cetera, right? And so that is going to ease up room. What I will tell you, I hear from clinicians is if you take the straightforward disease out of my practice, I was an adult congenital heart disease doctor. I had patients with Fontan, single ventricle. I can't now see 20 of those patients because that is hard, that is a lot, and actually they deserve more time. And so now the RVU model that we see a question about is coming up against, how are we going to offer ideal care? And I think we have to rethink what is value. So there's a CG CAPS thing, right? In outpatient cardiology, where you get graded on things like how well did you explain something to your patient? Did your provider listen to you? Everybody gets great scores at that in any cardiovascular practice. What they don't get a good score is I spent enough time with my clinician. Now imagine if you therefore wanted to get those scores up and you made that a value metric in your practice. Some of the hypertension patients who are straightforward, don't have to come in, don't have to miss work, don't have to find child care or elder care, get cared for at home by a somewhat technology team-based mechanism. And I'm spending more time with the complex patients in my office. That has to be valued. And so we have to realign to make that something of value. Fiscally, I don't know. And I'll look back to Deepak and Garth and say, how are we going to fiscally be able to defend that? But I think that's kind of one model that needs to change, right? Don't replace 20 visits with 20 more complex visits by taking the easier patients out. And I don't mean anybody's easy, but you know what I mean? Like it's a little bit simpler for us to be able to do this at home and allow the patient to be where they are in their community. The second thing I'll say is we are solving for loneliness as doctors. We are solving for loneliness. People like to see their clinicians, their nurses, their doctors, and oftentimes we are solving for loneliness, not for disease. And so we have to accept that that's part of that feeling of, how does it impact my relationship with my clinician? Well, what is that relationship and what are you depending on your clinician for? And that's a harder thing to address, but it's really, there's a lot of visits from people who consider their medical team their second home, whereas maybe medically it didn't need to be right now. And that makes it hard.
Yeah, those are a lot of great points.
Go ahead, Deepak.
Oh, no, I was just saying there's a lot of great points, and really the questions that have come in so far are terrific and right on the mark. I think there's a lot we can do, as a number of questioners have raised, with telemedicine, with wearables. I mean, is it really a good use of a doctor's time, even a nurse's time, the patient or family's time to come in for the routine blood pressure check? A lot of that really could be done remotely. Do you really need to listen to their lungs again? Unlikely that they've developed a new murmur or, asymptomatic pulmonary edema in the past week after starting or titrating a blood pressure med. So a lot of how healthcare is built is really because the in-person visit generates our views. And if we could move away from that model, I think it would help care. Ami also raises a great point. I mean, if you do part of that is you substitute the type of visits I mentioned with more complex stuff, that's great. That's a good utilization, certainly of the doctor's time, maybe the patient's time. But if you're saying do it in 10 minutes with this complex congenital heart disease patient, well, then you're actually making a bad situation worse. You're actually hurting the healthcare system, maybe patient care, contributing to physician burnout. So I do think payment models will need to be addressed with whatever we do next in healthcare. I mean, there are certain benefits to certain parties of the RVU system. Sanjay, proceduralists like you and me historically have done quite well with the RVU system. But even there, I think it just can create perverse incentives. And what might actually lead to change is just, a crisis. And I do think with respect to healthcare financing, we will one of these years enter a true crisis where collectively all stakeholders say, yeah, we can't just keep doing what we're doing. This is really unaffordable. Whether that's going to happen now, 5 years from now, I don't know. But I don't think we can keep doing what we're doing the way we are right now for the next 20 years, other than the sort of patient-centered issues we've been discussing. Just financially, I don't think it's viable.
But, Ajay, before you go further, I think I wanted to address the wearable part, but Ami brought up something that is really crucial when she mentioned the challenge with loneliness and I would say kind of related social and societal dynamics that are integral to our patients' lives and drive a lot of health outcomes. We as clinicians, and I think the more you get along the subspecialty track, sometimes the further we get away from our ability to even have the time to understand those concepts in a patient's life, realizing the heart is still part of that person's body and their whole life, and they're still the person that comes along with it. So it's important to, I think, understand those concepts. Now, there's tons of data to really show, from the analogies between smoking and loneliness and smoking and the risk factor dynamics there. But it's important to realize just how key those particular risk factors are, and the morbidity and mortality they drive along with that. The other part Deepak mentioned was, again, how can we even simplify some of these non-essential tasks that clinicians have to be a part of. And I do think, now taking this back to a question that came earlier, their wearables have a lot of promise. There are a lot of my colleagues in Google here who work on Fitbit, for instance, and there's a lot of work that we've been doing with Fitbit, particularly around rhythm detection, and even understanding more recently where loss of pulse, and that as a wearable can be one of the detecting factors there. But regardless, there's a lot to be thought of in terms of some of these corollary tools. How they get integrated in the workflow is important, and that's part of the one challenge. But two points brought up by Deepak and Amy I wanted to talk about, and that loneliness part being an integral thing that's driving morbidity and mortality that we don't pay a lot of attention to.
I think since the digital tools and wearables have come up a few times already, so maybe, moving on to the digital health in cardiovascular care. And I think a lot of time when we focus on cardiovascular care, we're talking about outcomes, right? So are there tools that are currently available, remote patient monitoring, wearable sensors, and everybody now knows Apple Watch, and you can look for AFib and those kind of things. Are health system ready to ingest all that data meaningfully, Deepak? If I have 1,000 patients in a practice sending me their data, how do health systems deal with that kind of data?
Yeah, I think that's really a great point, because when you talk about wearables and other sorts of, remote monitoring technologies, it's going to generate a ton of data. It is generating a ton of data. And I think physicians have a love-hate relationship with the data that are coming in. On the one hand, of course, it can help with patient outcomes, with safety, even patient satisfaction. But on the other hand, it's a lot more work. And if it's unfiltered data, it's a lot more work that may not be directly actionable. The physician may fear that there are medical legal implications to this mountain of data that are coming in that are unmonitored. So the reality is, if we just say, hey, we've got this neat new wearable, it's going to generate a ton of information for you, but don't set up a system to triage that data, to filter that data, it'll actually make a bad situation worse. It's sort of a situation that in many ICUs nurses face with alarm fatigue. There's just a bunch of alarms going off 24/7. Eventually the brain just filters out some of them, and it's hard to know which ones are actionable, which ones probably you can ignore. So we don't want to recreate that type of model. We want to create a model where information that is useful, that's actionable, filters up to the physician, or is just triaged to whoever's best able to handle that sort of information on the healthcare team. And I do think that just introducing a wearable without that support, which I think would, in part be AI driven, would be not even a helpful thing, but rather a hurtful thing to physician practices, and ultimately to patients, where they think they're providing information that's getting to their physician and is useful, but in fact may not be. Some of these wearable watches, smart watches, for example, they can detect atrial fibrillation, maybe, but the accuracy isn't always necessarily what we would want, or the perceived accuracy isn't. And I think part of the problem with wearables, especially in cardiovascular medicine, where we're so evidence-based, where so much of what we do is based on randomized clinical trials, is that these are introduced without data. That is, they may have regulatory approval from the FDA or other regulatory agencies, but they haven't actually been tested in a way that shows they improve any sort of actual outcome. So I do think if we raise the bar for wearables and say, hey, okay, that's great, you can get this, for fun, wear it around, but rather just see, does introduction of these sorts of remote monitoring technologies in fact improve outcomes, that would be better. For some things like invasive technologies, like the cardiomems, I'll give a specific example, their randomized clinical trial data actually showed value of that. Now that's an invasive monitoring system, but I think even non-invasive monitoring, while it doesn't have the risks associated with invasive procedure, there might be other sorts of risks of missing data, risks of just going down the wrong pathway with additional testing. If we actually tested these sorts of remote monitoring technologies in randomized trials that then hopefully demonstrate some sort of value before actually widely deploying them, I think that'd be really useful. Of course, it can be tough because much of this is patient and consumer driven and not necessarily healthcare or physician driven.
So my phrase of the year, and I'm sorry for people who've heard me say it too much, it's not consumerism, it's patient agency. We have to get used to that. And that is the answer to these wearables. And it means a few things. The first thing is the patient has to take responsibility when you're measuring things, that you're not just measuring it and dumping it on somebody else to figure out what happens with it. You have to understand what you're measuring, why, whether it's relevant to you. And we as clinicians probably do owe it to our patients to explain to them, these are the kind of things you should measure, and these are the ones that are probably not relevant to you. And that's a part of a daily discussion now that I think needs to happen, that didn't used to happen 10, 20 years ago because it wasn't relevant. What does that mean for the companies? I am swimming with digital health companies daily, big and small. It means that when you create something that you think is great, number one, your user interface isn't going to be the one interface that every clinician uses because they don't want 19 different interfaces. So if you have a really great digital health mechanism and you are new, start thinking about where you fit in the current workflow, where you fit in the platforms, who you could partner with such that data is coming in through an infrastructure. And if you're the big company, please work with clinicians to build the infrastructure. So we're not working with Google and we're not working with an orange or a banana. I'm not supposed to say who we're working with yet. We have a couple days till we announce. But one of the important things we've done at the ACC is worked with companies who do have both FDA approval and trials to now say, how do I teach clinicians to use your information? What does it mean? What research is it built on? How do I teach patients? And then how do I enable shared decision-making between a clinician and a patient about how often this should be used, what we should do? So it's hard. We're adding an entire new area of monitoring into a patient's understanding and a clinician's understanding, and we're making them talk about it, but we haven't taught anybody how to do it. And so it really is our job in education to now move forward and teach people, what does an infrastructure look like that's good for digital health? How does the clinician interact in the infrastructure? How does a patient interact? And so I think we need the companies, the clinicians, the administrators, and the patients to all work together. And the one I've left out is the payers. And I know that, and I see the comments there, because we have to explain to them how to get on board, right? And for that, we need outcomes. And I think real world data is going to be as important as randomized data to be able to really show outcomes moving forward, because randomized controlled trials are not the way these things are used in the real world. And we all know it. So real world data, I think, will be essential moving forward.
Yeah, I think it ties tangentially to something we discussed before, pipeline. Should med schools be teaching about digital health and AI? And I've seen some of that start, at least here at Case Western. So I'm curious if you've had any exposure to that.
Yeah, so a majority, if you kind of name a large hospital or health system, they are starting to insist that the medical students associated with their hospitals do it. So it's not only coming from the educators at the med schools, it's coming from the affiliated hospitals with these medical schools saying, hey, it would really help if they could do that. And increasingly, we're even getting to a point where those who are learning about it now are actually going out into the community. There's a recent article on should we be doing shadowing and internship again to become good clinicians? Should we be following clinicians again? In the few practices that I've been talking to recently where the med students are shadowing a clinician, they're actually also teaching them what they know about generative AI and digital health and wearables. And it's been a lovely two-way street. So yes, it is happening. It should happen more. And we can't forget people who are in practice right now they actually also need to have a curriculum somehow.
Dr. Graham, you were about to say
Oh
something.
yeah, so many points and so many good points in terms of understanding, data and workflow and the usefulness of data versus the uselessness of data. And I think that is really important for understanding. I think what is really clinically and practically applicable. The med student question is a fascinating one. Being on this journey of driving a lot of AI, both programmatic adoption, implementation, and working with large language models and doing this globally has been fascinating. But the most fascinating thing for me is, I also teach and lecture, and whenever I go in and do my AI class or my class, particularly one I do at the University of Florida, the students are way ahead of us. And I work at a tech company, and they've ingested and the questions and the things that they're feeding back to me in terms of questions about model building and understanding both the pros and cons when you're building a model is fascinating. So, Amy's point, I would just say that there's many parts of this generation that, from the application of these tools in their daily life, are already bridging these concepts from a clinical aspect, and figuring out how to do that in a more structured way is particularly important, because I think one of the points that Deepak made earlier, I think broadly, is structure and some degree maybe discipline is a word, but structure to a lot of this, I think, helps to make it a lot more productive. One last point I'll say is there are a lot of other applications around machine learning and technology that is outside of how we think of the traditional concept in terms of AI, which I think a lot of that is how we think about bots and large language models. Some of the predictive analytics that's happening from being able to pull together data at scale is particularly important. Even some understanding how we get even better EKG analysis, CT scan analysis, and some of that data. So there are different components to biting this apple. I think we're at a phase right now where we're biting the apple in multiple ways. But in terms of understanding the usefulness for a clinician is where this gets to be more practical, because it's then now about how we digest, coalesce, integrate this into workflow, and then make this productive. And that's probably where things start to get more challenging, as clinicians are already overworked from primary care to specialists already.
Yeah, I agree with everything God said. I mean, there's now, of course, a number of FDA-approved AI tools for ECGs, echoes, other imaging modalities that are, in daily clinical use. So, all that's really there. In terms of medical students, it's probably sort of like when the internet first came out, for those of you that remember that. I mean, where we would say, yes, the medical students need to learn how to use the internet. But the reality is, by the time we're saying it, they're already using it, probably better at it than we are. So I think the same thing is happening with different AI tools and, different large language models, different things like ChatGPT that are out there. Oh, right, I should be careful with Garth, whatever Google's version is. I think it's Gemini. It's also excellent. It's great. I use it. But, Open Evidence, NEGM, just partner with those folks. I've used that too. I mean, they all seem pretty good, but, the medical students and house officers I know are already using these things, playing around with them. So yes, it should be in the curricula. Yes, we should teach about it, but probably they're going to be teaching us about it when we go on rounds with them.
I think since AI has come off in multiple, conversations, and, even now we kind of tangentially moved from digital health to AI, and we talked about outcomes. So how do you really assess so two questions with AI. I think one is, how do you really assess AI-based outcomes? And maybe, how do you study AI in clinical trials or real world, then you can then bring back. So maybe Ami, Deepak, or Garth, whoever wants to go first.
All right, I'll take part of it, and then I'll leave part for both of my colleagues. In digital health in general, to make the kind of line from digital health to AI, because where is AI being used, right? AI is being used upstream in the things that we already do, right? It is not an end-all be-all thing of itself. It is allowing us to be more efficient, to find the patients, to direct things to the right place, to gather information together, source it, and parse it for the human brain. And so I think it's important to recognize that AI is always part of something else. So let's take digital health for an example. When we first started digital health, we were very excited because engagement was considered an outcome. Look how many people engage with this chronic glucose monitoring. Look how many people engage with the blood pressure. Not look how many systolic blood pressure points went down with use of this. Not look, the hemoglobin A1C improved this much in these companies, because we were just trying to get engagement. So it is time for that whole culture to shift to outcomes. And I think we can have better outcomes with AI, but the measurement of outcomes needs to be there. And so as these methodologies and these AI algorithms come through things like regulatory bodies, what we need to say is not only, yes, you have enough technical know-how to be able to give this to people and use it clinically, but what are the metrics that you're measuring on the far side? What do you expect to see? What are you going to change if you're not seeing those outcomes get better? And I think that is what we need to demand now. In order to leverage AI for actual outcomes, is we need to demand that we see the metrics on the far side, right? What are those metrics? And that goes back to my real world question, but I think we need to see metrics on the far side that are outcomes-based metrics, and that's how we'll know that AI is doing better. Now, let me give you one specific example. We talked about prevention. You asked about this earlier, Sanjay, right? What about moving earlier? At ACC, we have a large effort called Prime Heart. The LDL urgency falls under that, which is we should be thinking about heart disease when people are much younger, in their 30s and 40s, not their 70s and 80s. And I have a chip on my shoulder, and that chip on my shoulder is all the cancer people. They are so good at prevention. Everybody gets their mammogram. People get their colonoscopies. Not everybody gets their colonoscopy. We're trying to do better. But we're not doing the same for heart disease. And yet heart disease kills more people than all cancers put together in the US. And so how do we move earlier? If you use AI on a CAT scan, you can, number one, use AI to find adequate calcium on a CAT scan, even though it wasn't aimed at the heart, to be able to tell someone. You can do it in a mammogram, or you can look at plaque if you're an interventionist like the two of you, and you can say, hey, this plaque is not only present, it is dangerous. This is a plaque that's going to rupture. And now we're doing something that looks more like cancer. We're starting to rank and risk stratify earlier. Those are going to show us outcomes. And those are going to be some of the ways we're going to be able to get people to understand how AI makes something like a CAT scan better, how AI makes digital health blood pressure monitoring better, because we triage sick for not sick. We get the right people to the right care. And so I think that model of moving upstream, using AI, but then still demanding outcomes, we have to set that model up for people.
Yeah, I agree with everything Ami said. I'm involved with a trial, the Transform trial, where we're doing some of what you just said. And in fact, the ACC's been a partner on that trial. And basically, it's trying to take primary prevention to the next level, trying to use coronary CT angio, non-invasively obtained, of course, and AI-enabled characterization of plaque to stage plaque, coronary plaque, in the way that a cancer doctor might stage cancer, and then titrate the intensity of therapy based on the stage. So we're randomizing primary prevention patients to usual guideline-based care or to this AI-enabled CT screening, and then intensification of medical therapy based on the imaging to see if that improves outcomes or not. So I think, and that'll be 7,500 patients. We're already well into the trial. So I think those sorts of approaches, asking a question, this goes back to what you mentioned before, Sanjay, about prevention, though it doesn't have to be about prevention, testing some of these new technologies, but doing it in a randomized, objective, rigorous sort of way is what will really move the field forward. And I think, going back to the wearable issue before, I mean, you're right. In many respects, the horse is out of the barn. Patients and consumers are going to do as they like. But I think we can still insist that companies do what they can to actually test these technologies, even post-deployment. And Garth, you're obviously in a position where you can do that. I would urge companies like Google, where you've got a ton of technology that's really cool technology. Yeah, you can just get it out there. People will, of course, buy it because it's new and cool. But what will really advance the field scientifically and ultimately clinically, I think, is testing any of these new technologies, whether they're wearables, AI tools, et cetera, in a rigorous sort of way to see, do they actually add value in terms of advancing patient care, ultimately patient outcomes.
Yeah, and Deepa, I think that's a really good point, and a lot of the work that's still ongoing to test a number of things that we have in the works and that are out there already. One of the points I did want to make, Sanjay, to broader thing around effectiveness. You know, I view, I'd say our teams view AI as a tool, not the end all be all, but the clinician being the primary ongoing kind of orchestra of the patient's healthcare journey, and all of these just being additional tools to either help or advance patient care in general. So I think in the context of that, the outcomes still continue to still be the outcomes that are beneficial to the patient who's at the center of this, and then the clinician who's delivering the care. So I think it's important for us to think of these as tools and as not the whatever the technology is, as not the primary focus of that interface. But I think I'm going jumping back to the last point. I think Deepak made as I think a lot of public-private partnerships emerge, more it allows us to still continue to get into a lot more of how we kind of advance the science along this this area in general. It sounds like ACC may have some fascinating plans coming up too.
Yeah. You know, one of the things that talking of AI, previously we talked about how patients crave interactions with the physician and how it addresses loneliness. So do you think AI, so this is one of the questions, will the technology, digital tools, AI impact my relationship with the doctor? Will it enhance it? Will it distract from it?
Yeah, so Sarah asked two questions. I want to just answer her other question quickly. Implementation challenges for AI in healthcare. Pick the right problem. Pick the thing you really want to solve for in your practice for your patients. Then you will not have difficulty because you will still be driving towards it no matter what. If you say that's a cool tool, my friend knows it, and therefore the CEO is going to try and implement it, it's not. AI doesn't work out of the box. AI never works out of the box. It may work in its trial. It may work for the FDA. Your population will be slightly different. It will be something unique. The people who are using it are unique individual humans. So it has to be a problem that really matters if you're driving towards when you use AI. So that's the first part. Sarah, the question of how will AI and technology impact your relationship? Used correctly, it is a way to show respect for patients in the communities where they live. It is a way to say the first mile of healthcare is with the patient, not the last mile. So we will find sick from not sick in your home. We will help you feedback and understand, hey, I'm doing well, I'm not doing great. And the wellness industry of wearables has already done that brilliantly. We're trying to now adjust that into the healthcare side and see how it is. But I'll give you an example that is not AI, it's telemedicine. But when I first started doing this, it was 2013, I started telemedicine. And nobody wanted to do it with me, by the way. So like for those of us who started back then, this is so exciting. It's like, oh, you know, now finally people get it. But not all the payers get it, but they're starting to. But when we started back then, I really, I'm a Norman Rockwell kind of doc. Like I want to sit with my patient, hold their hand. And I had a patient who needed his third surgery. And I called him and I was like, come in, right? Come in so we can sit and hold hands. He lived 4 hours away from Boston. And he said, no, we're going to do the telemedicine thing. And I was like, not for this, we're not. And he knew, he felt really ill, right? He understood. It was after testing, I'm asking him to come in. He knew. And finally, we had the conversation over a video, Sarah. Like I talked to him and told him he needed his third surgery over video. And I didn't feel great about it. And after he was done we were done with that conversation, he asked his wife to leave. They were on their couch at home. His wife left and he said, thank you, doc. And I was like, don't thank me. Like we need a third surgery here. And he said, no, thank you for doing it over video. I know it was really uncomfortable for you, but it was really important for me to be here at home with my family because they're the only reason I'll do this a third time. That's where we want to get with AI, with technology, right? That is respecting the patient, putting the patient first. And so I'm hopeful that we keep that in mind. And if we keep it in mind, I don't think we'll go wrong.
Yeah, I think that's a great point. I think, you know, during the pandemic, we learned a little bit more about telehealth than we did before and what patients consider acceptable and not acceptable ways of interacting with various healthcare professionals. Of course, you know, it can be different. It is different for every patient. But I think pandemic showed us that a lot of folks actually are just fine with telehealth and don't have to find a babysitter, don't have to take a day off from work. I mean, there are a lot of different things that are advantages. And I think we need to really embrace it. Certainly, as Ami referred to, payment models haven't totally allowed that embracing. There's been some recidivism after the pandemic in terms of telehealth, unfortunately. But I do think there is a lot of value here. But Sanjay, to get to your question of AI, is it good or evil? I think the conversation really is like the internet when it came out, where I don't know how well all of you recall this or if you were totally around for that transition, but there were people saying this is going to be the end of the library. I mean, this is horrible. People aren't going to go to the library anymore. And, libraries are still there, doing pretty well, maybe not quite as well as they were pre-internet. But, the internet, to me, it's just like AI. It's an amoral thing. It's not inherently good or evil. It might do great things. It might do bad things. Same with AI. It's really a tool and how we use it. So I think in medicine, we should embrace it. Those of us that are clinically active should find ways of molding its applications in healthcare, making sure that it is useful to healthcare providers, to physicians, to patients and their families as possible, and try to do what we can to take the edges off it. I mean, certainly there have been concerns how AI as deployment in healthcare or other settings, can increase bias instead of decreasing bias. But as experienced physicians, I think there's input we can provide to make sure whatever models are used, are kept in between guardrails so that things like that don't happen. So, the key is to not be really afraid of deployment of AI or, just technophobic, but rather embrace it, but, study it, make sure that other stakeholders are also investing the time and resources to properly study the different AI tools as they're being deployed, before they're being deployed when possible, but not to take an approach of, any sort of change is bad. And the reality is, even if one thinks that AI is going to be, sort of a Terminator type scenario, the genie's out of the bottle. I mean, the field is moving at a quick pace, and it's silly to try to resist changes.
But I think to your point, rather than be afraid of it, we need to play a role in shaping it. I think this is where, the clinical experience really lets it be molded in a way that takes care of the patients and put the patients at the center of it. We have 2 minutes left, and so maybe I want to give each of you the last closing remarks that you would like to close this conversation.
Well, then I'll jump in. I'll say that I think this has been a lot of fun. It's been very educational for me. As always, I've learned a lot from Ami, and additionally a lot from Garth. Really great getting a chance to interact with you here as well. And Sanjay, wonderful being reconnected with you. Thanks for organizing this.
Thank you. Garth?
Yeah, I'll just say I'd also learned a lot, and actually I've come away with this with two ideas. So thank you, Deepak, for your wisdom, and Amy for your wisdom and passion as well. And I just want to underscore this idea that these are tools, and that at the end of the day, the lives of our patients are still the ultimate goals, and the ultimate reason I think many of us get in this whole medicine gig to begin with. So as long as we keep that at focus, I think it'll be particularly important.
Thank you for having me. I always learn a ton from all three of you. The slide before this, Sanjay, you had up said, what can cardiologists and administrators do now? And I'd like to answer that as my closing thought, which is we need to not say technology is happening to us. We need to, yes, be involved earlier, but we also need to share what are the problems that need to be solved, because we are oftentimes taking the new technology, the new AI, and trying to put it into what we are doing. And that, I would say, is a little backwards. They should be designing for us, right? These are our partners. Technology people are our partners, should be designing for us. So we need to get out there and say, here's what I need you to design. And whether that's an individual meeting with a company, or whether that's when you give a lecture or you teach people or you talk to your patients, tell everybody what you're looking for from technology. And I think that groundswell is going to make a real difference. The last thing is, we oftentimes do things as, well, we're making this big change. Let me tell you, change is permanent now. in this day and age with this kind of technology, AI, digital health, there's not going to be a point where the practice of medicine isn't going to change. It is going to be changing incessantly. We have to get used to that, and it's hard. But we have to get used to that. It is a constant culture of change now. So sooner we accept that and we become part of it, I think the happier we'll be too about the combination of tech and really putting the patient and the clinician at the center.
So thank you all. I think I learned a lot with this conversation as well. I know we have a few more unanswered questions from the audience. We'll try to do it separately, but 3 things that I heard: embrace change. Yeah, I think we need to be part of it. We need to shape it. Second, put patients and providers at the center of what is being done. So instead of being driven by technology, let health system and healthcare providers and patients lead us in this journey. And let's all work together, whether it is technology companies, whether it's clinicians, whether it is payers and policymakers. I think that's a very important message. So thank you all for a very engaging conversation.
Thank you.
Thank you.
All right.